carotid and deep overjab in mixed tissue cover. Carotid narrowing of the arch. This is the whole pitch and self. Mixed tissue there. And the mandible morphology is flat and rectangular. We shall know the morphology of the mandible. It's quite important. When the patient is at over 10 years old, the morphology of the mandible is quite obvious. But before 10 years old, we cannot tell the morphology of the mandible because all children, the morphology is the same. But after 10, they will change. So we can tell. We can tell the classification. We can tell we can predict the growth of the patient through the morphology of the mandible. So it's quite important. I will emphasize the point again and again during my lecture. So this case, of course, I think it's not a so difficult case, but it will take quite a long time. It will take more than 2 years. So if a case takes more than 2 years, I suggest you choose smartee. You do not need to choose smartee Skinner. Smartee can solve everything. Expansion, just expansion. Then have space to retract the anterior incisors. So this is the 14th step. And the 14th step, we find that the two primary teeth missing. So we need to wait. We need to wait for the eruption of the permanent teeth. So at that time, what shall we do now? We can use the what device? So tell me what device? Pronounced is joy. Yes, joy. So we have joy. So we have joy. So you cannot do, and you must do something. You cannot wait. You just wait. You must give the patient something. Joy. So at the end, for some time, the joy, the permanent is erupted. Then we continue the treatment with liner. So in mixed dentition, maybe we need to wait, but we cannot just wait. We must do something to let the patient know that I'm very helpful to you, and I will take all my heart, try my best to help you. You cannot just wait. If you keep in touch with the patient, and tell the patient to come back 1 or 2 months, then the patient will trust you so much, and will cooperate so well with you. And this is the phase 2 admission design. Expansion, align teeth. So quite simple, I think. Just may take some time. Very good occlusion. And then refinement to get better alignment of teeth. So I think it's a quite simple case, but it's just because it takes more than 2 years. So we need to use the smartee. So this is after treatment. Good profile, go to front of view, and go to occlusion. This X-ray, the roots are quite upstream, and the self shows a good view of the good morphology of the mandible. So we take more than 2 years, nearly 2.5 years to finish this case. And we do not, all the time, we do not use the aligner. We just wait for some time to use the joint to help the eruption of the permanent teeth. So that's a quite easy case. Then we'll come to a more complicated one. We come to the class 2, class 3 cases. So class 2 and class 3, what's the smartee solution? What's the weapons we provide you? In class 2 face shop, we give you S8 device for multiple advancement. And class 3, we can provide you the S10. It's a mandibular repeating device with occlusal split. And the S16, invisible forward traction device. So the device may be so simple, but we need to use them in many different ways. So first let's talk about class 2 facial shape. How to diagnostic class 2 facial shape, what's the treatment method, and what's the treatment time. Class 2, I mean animals classification, class 1, class 2, class 3. Really tell us nothing. Really tell us nothing. Class 2 cannot tell us whether the patient can extract teeth or not, or whether the patient needs mandibular reposition or not, or whether the patient needs surgery or not. So we need a new classification. We need a new classification of malocclusion with facial pregnancy. So it's invited by Professor Constant. So let me talk about the classification for you. So I think if you know the classification, you will do a very good job in diagnosis, in treatment plan. So we divide the facial pregnant patients into 6 subtypes. The first 2 subtypes are fundamental subtypes. Let's look at these first. This subtype, we call it dental alveolar originated subtype. It means only dental problems. First, we can see that the bone, the maxilla and the mandibular they are very normal. They have no problems with the bone. They just have some up incisors proclination, quite proclination. So the patient have a very deep overjet. Yes, very deep overjet. But the molar relationship is not class, it's still class 1. It's still class 1. And the lower dentition is relatively aligned. So the lower dentition have no deep curve speed, and of course, no deep overbite. So this kind of patient, they only have deep overjet and some space on between the teeth, and shallow overbite and shallow curve of speed. So this is which means the 1 deep, 2 shallow. But 1 deep, 2 shallow and the class 1 molar relationship. And you can find the profile, the lips are quite loose. So we need to have the lip training, muscle training. We need to use the myofunctional trainer to help to enhance the lip muscles. And the self, we can find the self is that we can find what's the morphology of the mandible. It's we shall know that it's flat and rectangular shape. Very beautiful mandibular morphology. So this kind of patient, I think, is quite easy to treat because the molar relation is class 1, and we just need to put back their anterior teeth. So we can use the maybe we can use fixed braces, or we can use aligners. We can use everything you can to retract anterior teeth. Then the case is done. And of course, maybe you need to train their muscles to help with the better retainer, for better retention. So this is the most basic fundamental form of the face pregnant subtype. Then, if the patient have this subtype, but the patient did not be treated so in time, then this kind of male-canoid subtype will develop to this type. So let's talk about this one. We call it mandibular position regnate subtype. So when this patient, they have normal maxillary and a normal maxilla and a normal mandible, but with time going on, the mandible will surely, gradually retreated because they have a mouth breathing problem. They have so loose lips. The upper arch will become narrow and narrow. And when they narrow to some degree, the mandible has to retreat back. Why? Because the patient wants to survive. The patient wants to chew food. Because the upper arch is narrow enough, so the mandible must to retreat to adapt to get better occlusion. So the molar relationship comes from class 1 to class 2. Okay? So it's the reason why this is class 2. It's not because of the misalignment of teeth. It's because of the narrow of the arch. It's because of the mouth breathing. It's about the mispositioning of the tongue. Then cause the narrow of the upper arch. Then the mandible retreating. So the molar relation comes to class 2. And of course the up incisors quite preclination. The same with the basic one. Then we found. So this is class 2, and still, of course, still have deep over jet. Yes, and because class 2, because deep over jet, and with time, it always need time. With time going on, we gradually have deeper deep over bite. Gradually we have deep over bite, and gradually we have deep curve of speed. So understand that? So we have in this kind of subtype, we can find 3 deep. Deep over jet, deep over bite, and the deep curve of speed, and class 2 molar relationship. So this mandible position originated come from the dental alveolar originated. But this is class 1 deep to shallow, and this is class 2, 3 deep. And the morphology of the mandible, of course, they are thin. They are flat and rectangular. So, if you treat this kind of patient, how could you treat this one? First step is, what's the first step? Is does it need extraction? Because it has big over jet, it's a molar 2 relation, so maybe some doctor will extract 2 upper premolars, then to retract the anterior teeth and move the molars forward to get a 4-unit class 2 molar relationship. So maybe some doctor will do that. Of course, I once did it 20 years ago. It's quite common at that time. But now we know why the class 2 molar should come from, how it come from, how the 3 teeth come from. So we must, at the very first step, we must move the mandible forward to the original place. Original position, the mandible should be there. To restore the mandible to the original position. So we'll come to the basic one. To restore the class 2 molar relationship to class 1. Then we just need to retract anterior teeth. We do not need to extract any teeth. So that is the mandibular position original type. How to treat this type? We need mandibular advancement. We do not need surgery, or we do not need extraction. Okay, can I explain it clearly? Now we talk about the second fundamental subtype. This is called skeletal originate. And what's the emphasis is the physiologically. Physiologically is the relatively to, this is pathologically, and this is physiologically. So, what's the characteristic of the physiologically type? The occlusion is perfect, very perfect. We have nothing to do with occlusion. The occlusion is class 1. Very good over jet, over bite, and flat curve speed. So, from occlusion we can do nothing. But patients always complain about their face. Very protruding lips, very protruding bones, by protruding. We talk about this is by protruding. So how to treat a by protruding case? I think it's quite difficult to treat this kind of case because the teeth are quite upstream, not protruding, quite upstream. The bone is quite overgrown. Essentially very overgrowth, and transversely very overgrowth, and vertically very overgrowth. So it maybe gummy smell. Everyone has gummy smell. So the patient did not do not satisfy with the face with the smile. So it's quite difficult to treat this kind of patient. When the patient is small, is the child, maybe we can extract teeth, extract 4 premolars. Then we retract anterior teeth, and the bone will adapt to the teeth. So that will be that will be okay when in a child we can extract teeth. But when the patient grown up, well, we are so cautious about the extraction because it will ruin the face. So when they grow up, maybe we suggest the patient to do surgery. Surgery is better, it's the best way to change the profile, to change the aesthetics. But if the patient do not want surgery, maybe we suggest them to dislice molars to get a bit change, but do not change much. So it's a quite difficult case, actually. And the morphology of the chin here, we cannot change it. It maybe when they grow up, we can do some surgery, or we can inject something at this way. But the patient has no chin here. We can do nothing. Why the patient have no chin? Because you can find at the self it's different. It's different shape from this one. So what's the different shape? It's the shape of the mandible is we call it triangle. Triangle. So it always have a vertical growth, not sexual growth. So this kind of patient, we always find the kind of patient, the lower third is quite high, the face is quite low. So it's not good looking. And have no chin because the chin, they grow vertically, not sexually. But it's health conclusion. So maybe when I see some patient with this kind of conclusion, when the patient is about 20 or 30 years old, to see Dr. Wu, I want to change. So I always say, you are so good looking, you have no reason to do anything. So I always refuse them to do something because I think I can do nothing to better their aesthetic. So they must come back to their mother. Why you be such a triangle shape of the mandible? But for me. But triangle is not a good morphology. It's always a bad morphology in face pregnant patients and in face reclined patients. So we must have an impression that flat and the rectangular shape is good, and triangle shape is bad, always bad. If we met patient with triangle shape, it means difficult case. So this fundamental is difficult to treat because the teeth have no problem with teeth, but just problem with bones. But orthodontic can only treat with teeth, not with bone. And the triangle shape have problems because this kind of patients will have TMT problems in the future. When you see the patient is molar class 1, but don't forget, in the future, the patient, the molar relationship may come to class 2. Why? Because triangle shape mandible will have TMT problems 99%, almost 100% will have TMT problems. Why? Because the mandible grows vertically, not sagitally. So the TMG here, the disc here, are quite easy to have something wrong, to have problems. So if the TMG have problems, we'll come to this one. The third type, we call it skeletal originated pathological. What means pathologically? It means TMG problem. What's the problem of TMG? The conduct resorption. Because why the conduct will get resorption? Because the disc place is wrong. So when the conduct have some resorption, the mandible will retreat back and have a rotation, have some degree of rotation, some degree of clockwise rotation. So there's an open bite here. You always find an open bite. And of course, a very big overjet. So this is a big overjet, and we find that is a shadow overbite, maybe overbite, and the shadow curve of speed. So it's always the 1 dip to shallow. So 1 dip to shallow, we have 2 1 dip to shallow. This is also 1 dip to shallow, but this is class 1 molar relationship. This is class 2 molar relationship. So they're different. So this one, if the mandible retreat, it always come to this mandible position time. So this 1 dip to shallow comes to the 3 dip, but this 3 shallow will come to 1 dip to shallow. Molar relation is class 2. So maybe you are confused about it, but you must check this table, this picture. You will find the reason why it comes from, how it comes from, so you can understand. So if you find a patient with 1 dip to shallow and with molar relationship maybe class 2, or maybe class 2, 4 unit class 2, it means the mandible retreated pathologically. Pathologically retreated will come to 1 dip, but physiologically, we call this physiological retreat. The physiological retreated because of the occlusion. So physiologically retreated mandible comes to 3 dip. Pathologically comes to 1 dip to shallow. So that's quite different. So there's still 6 subtypes. We just talk about the 4th subtype. Then we have the last 2 subtypes. We call them combined skeletal and mandibular position originated subtype. Combined subtype. Combined skeletal and mandibular position. So how to understand this? First, we look at the maxillary bone. Maxillary bone is quite similar with what fundamental type. It's quite similar with this one. The maxillary bone is quite overgrowth in 3 dimensions. 3 dimensions: the sagittal, vertical, and transversely, and they always overgrowth. And this one, the two types of the combined types, the posteriorities are very palatally inclined. Why the palatally inclined? Because of the quite overgrowth of the maxilla transversely. They don't need to expand the bone. We don't need to expand the bone of these subtypes. It's quite overgrowth. And the teeth have to lingually incline or palatally incline to fit the lower arch. So it's quite inclined, palatally inclined. And posterior because of the overgrowth of the posterior transversely. And vertically, maybe these two kinds of patients have gummy smile. So we, of course, in general treatment, we need to intrude up incisive to get a better smile. This is vertically. And sagittally, overgrowth, very overgrowth. This is moderate overgrowth. This is quite severe overgrowth sagittally. So the teeth here are quite straight because the teeth do not need preclination. It's just because the bone is quite overgrowth. The bone very overgrowth, the teeth always up straight. So this is quite similar here and quite similar here. Overgrowth bone with straight teeth, with straight front teeth. But normal bone with preclination of the teeth. Do you find it characteristic? The bone and the teeth, their relation, we will find in detail. And if the sagittally quite severe overgrowth here, the anterior must be quite reticline. To hide the severe of the overgrowth, to maybe have some function of the anterior teeth. Because even if the up teeth, front teeth is quite up straight, the patient cannot cut food with front teeth. So it's quite reticline because the bone is quite overgrowth. So this is more severe than this one. So this means skeletal overgrowth of the maxilla. And because the posterior teeth are palatally inclined, the mandible has to retreat back to fix the arch shape, to fix the arch shape to get a occlusion. So the mandible retreated back because of the upper arch, because of the palatal inclined posterior teeth. So quite similar, like this one. This is mandibular position originated. Why the mandible retreat back? Because the up arch is quite narrow. Because of mouth breathing, because of tongue rock position, quite narrow, so the mandible might have to retreat back. Quite similar, like this. They are the same reason. These three sometimes are the same reason why the mandible will retreat, because of the occlusion, because of the up teeth. They retreat back. So we call this retreat mandible physiologically retreat. They always physiologically retreat. So this mandible retreated, we call it mandibular position arrangement. So the name is the combined skeletal and the mandibular position originated subtype. This is combined subtype 1. The up front teeth are quite straight, and this is combined subtype 2. Very reclined up teeth. That's the difference. But the morphology of the mandible It's very good. It's flat and regular angulation. Flat and regular angulation. So I have introduced you the 6 subtypes. And this is the most easy case. And maybe this is the most difficult case. And the other 4 subtypes, they have the common place. Is that the mandible retreat. Okay, the mandible is retreated. And this one is pathologically retreated. It is because of the carnal resorption that the mandible retreated, so it is pathologically. And these 3 subtypes, because of the occluding, then the patient, the mandible retreating, so it's a physiological retreat. So if you find the one 2 shallow case, molar relation with class 2, or you find the 3 case, molar relation with class 2, what would you do? Of course, we need to put the mandible forward. If in this subtype we put the mandible forward, then pretend to be this one. This pathologically moved forward then to the physiologically type. Then we treat the patient. We treat this type of patient like this one. Yes. And these 3 subtypes, we put mandible forward. We put mandible forward. Then we get a good molar relation class 1. And then, do we need extraction teeth? No. Absolutely no. If you see you match case with 3 teeth, you just need to put the mandible forward. You do not need to extract teeth. So you should remember 3 teeth, no extraction. 3 teeth, no extraction. And 1 teeth, maybe need extraction, but first we need to put it back to this one. Move forward, move mandible forward, then you can think about whether we need extraction or not, or whether we need surgery or not if the mandible will not. So let's have a break so we can think about that. Then I will talk about cases. So use this classification. Okay, have a break.